urologist at North Shore-LIJ, and we are privileged to have Dr. Lewis Potters and Dr. Vira with us today to discuss the benefits of a collaborative approach in determining the treatment for prostate cancer. Dr. Potters is actually the chairman of radiation oncology at North Shore-LIJ Health System, I should say. And Dr. Vira is a urology oncologist at North Shore-LIJ Health System. Thank you guys so much for joining us.
Thank you. Thank you.
So I think this is a great topic in terms of a collaborative approach for prostate cancer. And we want to invite all of the viewers. We want to let them know that this is an interactive Google Hangout. So if they have questions, they're going to throw their questions in while we're talking. Dr. Potters, you want to tell us a little bit about yourself and your background?
Sure. So I'm chairman of radiation medicine for the health system, and I've been here for about 8 years. My clinical expertise has been in treating prostate cancer. I've been in practice close to 25 years, and I've been treating men with prostate cancer throughout that time. I have multiple publications and lecture about prostate cancer. It's one of those types of diseases that is, and we'll get into this a little bit. I like to think of it as like a small c type of cancer, not a capital C cancer.
Okay.
Most men have low risk disease, and that creates opportunities for them, and so it's been a privilege to do that for take care of these guys for the last 25 years.
Wonderful. Dr. Vira, can you tell us a little bit about your background and your expertise?
Sure. So I was recruited here from the National Cancer Institute, where I did my fellowship in urologic oncology. I've also been here about 8 years. I think Dr. Potters and I came around the same time. I treat prostate cancer as well as other urologic cancers, and primarily from a surgical aspect as a surgical oncologist. We offer the state-of-the-art surgical therapies, including robotic surgery, laparoscopic surgery, as well as active surveillance for patients who may not need treatment. And I'd like to echo Dr. Potter's comments on prostate cancer in that it's not always a big C cancer. It is a small c cancer for many men. And I often tell patients that prostate cancer may be the least dangerous cancer I treat or see patients for, but it's also oftentimes the most difficult cancer to treat, evaluate, make decisions on, and I think that's one of the values of having dual consultation and a team-based approach, is that you have multiple experts along with the patient, coming to a consensus decision about what's the best thing to do.
Wonderful. Well, I think between the years of expertise between the two of you, I think you're perfect to discuss the concept of the collaborative approach for prostate cancer. Do you want to let us know more about that and what that would entail?
Sure. So let me dive in. Men are diagnosed with prostate cancer, and any time a patient is diagnosed with any illness, let alone a cancer, there's a certain sense of heightened anxiety with that, and then there's this decision process about what's the approach, what's the best way to take care of this, and there's a sense that there's an acuteness and there's a fire drill aspect to needing to deal with diagnosis of cancer. And as we both alluded to, prostate cancer is not an aggressive disease, generally speaking. Almost 90% of men who are diagnosed today, have, disease that doesn't require a treatment decision to be made within 48 or 96 hours. So that there's plenty of time to sort of think about it, to become educated, and to understand, the disease and the treatment approaches. And because prostate cancer can be treated different ways, whether it's surgery, different aspects of surgery that Dr. Vira will go through, or whether it's different aspects of radiation. You can have external beam radiation, you can do radiosurgery, you can do seed implants. And then there's other modalities such as cryotherapy, freezing of the prostate, and other approaches as well, or the combinations of treatments, whether it's surgery with radiation afterwards, radiation with hormone. I could go on in the context of how confusing the options are. it's important that the patients really develop a sense of understanding about the disease. They understand the prognosis, and then they have time to start to think about it, either with their spouses or families, in terms of what might make sense or what might be the best approach for any patient. And because, I'm a radiation oncologist, Dr. Vira is a surgeon, and we all have biases in terms of how we present or discuss with patients. And because patients probably should see both a urologist and a radiation oncologist in the decision-making process, it's helpful for the patients to see the two of us together at the same time so that we can discuss the patient's or the family's biases about which treatments might be the best approach for them, whether it be surgery or one of the radiation options. Because we feel quite strongly about not being aggressive for most men with low-risk prostate cancer, and we can define what that means in a minute, by putting them on what's called an active surveillance protocol, and not treating them initially, or treating them when the disease progresses in such a way that it manifests itself as needing treatment, versus perhaps not needing treatment at all for years on end. Convincing patients to not be treated initially for cancer is sometimes harder than saying, okay, we'll just cut it out, or okay, we'll just radiate it. And having the two of us together to work with the patients and their families through that decision process is a tremendous sense of relief, and it kills two birds with one stone in the context of timing and being in the same building. Leads itself to that type of consultation discussion.
Right. I mean, I would add that part of our approach is to make sure that we obtain all the information necessary, and we really have developed a program to be able to optimize the assessment of the patient, assessment of the cancer by using MRI, obviously validated questionnaires to really assess sexual function and urinary function, integrate not only the patient, but the patient's family into the decision-making process, and then obviously integrate the various medical specialties, whether it be radiation medicine, urology, even medical oncology in some circumstances, to really try to tailor the right approach to the patient rather than a one-size-fits-all. Oftentimes patients are seen by a physician. If that physician is inclined towards surgery or radiation or whatever the case may be, that's what's offered and that's it. Right. And we're really trying to offer all of the approaches, inform the patient completely about the potential advantages, disadvantages of each approach, and then, together again, try to make a decision.
So this is a multidisciplinary approach that is the wave of the future in order to offer a personalized treatment option for the patient, but the patient still may not understand necessarily why he has to see you, Dr. Potters, and you, Dr. Vira, in the same day. What would be the difference in the discussion in your consultations?
Well, I think I think when we do this clinic, what really works well is that the two of us play off of each other pretty well, there are certain inherent biases that we all have. There are patients who are deadly afraid of surgery. Sure. There are patients who, fear radiation therapy or believe that cutting the tumor out is the best way to go. As Dr. Vira was saying, patients will fill out certain questionnaires, so we understand to some extent, what's important for them in terms of, what aspects of treatment or the side effects of those treatments are going to be problematic for them, whether it's sexual, urinary, bowel, whether they want to be treated and see the PSA, the blood test, respond right away or not. And so we can play off of the patient and their family and tailor the discussion to what makes best sense for them. Okay. And usually that works really well. Because we can tell, the wife is usually, a lot of times it's the wife that's the one that's, sort of driving the car a little bit with this. But we can trade off of their interaction in terms of helping to define what's right, and that sets a nice comfort zone for them when I'll say to the patient, I really think, you're going to be better served with surgery, and you're going to, spend a little bit more time now with Dr. Vira, who's going to discuss that with you, or vice versa. And I think that interaction is important for the patient.
And certainly living in New York and Long Island, we really see a variety of different types of patients. There are some patients that come in who've done a lot of research, who have maybe seen other physicians, who really have just more nitty-gritty questions about radiation therapy or surgery, and will use their own decision-making to make a decision. And we have some patients who really come in with no knowledge and are really looking for guidance and so forth. And so, I think having the dual consultation allows us to, again, best inform the patient, give them the nitty-gritty about what's involved with each approach, as well as try to give a somewhat opinion about, from our two standpoints, about what may be the best treatment for that particular patient. So it really facilitates seeing a variety of different patient types with different types of goals in terms of their consultation. And certainly, the convenience of being able to see two experts together, one visit, it's less time out of their day, it's less days lost of work, less days lost work for family. Oftentimes it's the patient can come in, but their children can't, or their spouse can't, or whatnot. So, I think there are a lot of advantages to having this type of approach.
See, and Jen, I think you said it. You said it best. It allows us to personalize a decision for the patient, and when there are potentially as many as 6 or 7 different options in terms of how patients may be treated, the fact is that we're not selling any one option to the patient. So even in Manhattan and elsewhere in other academic centers, your consultation, your evaluation with a specialist is usually limited to what that particular person, is an expert in. So if you go to a big cancer center in Manhattan, say, for an opinion, that opinion is going to be based specifically on who that operator assigns you to as the physician who you're going to see on that particular day, with all of their inherent biases and interests in wanting to treat you. And so, the idea of the North Shore Cancer Institute having multiple options, pretty much every option that there is available, with experts in each of those options, and then to open them up in an unbiased way between the two of us and have that discussion with the patient, allows us to personalize that decision making with the patient. And that's something that's really unique. That's not something that other centers have. You'll see places market certain technologies. You'll see other centers or hospitals market individual physicians. But that approach to prostate cancer is really trying to get everybody into the same shoe size with the same approach, and that's absolutely contrary to our approach in terms of how we deal with patients and families.
Right, and the reality is, in prostate cancer, oftentimes it's not just one physician that's going to end up treating them. Whether a patient has surgery and may need adjuvant radiation therapy, if a patient has radiation therapy and then may need salvage cryotherapy or salvage radiation after surgery. Again, being able to meet both teams, be integrated in both departments as one, really facilitates the coordination of care throughout the life of their prostate cancer treatment, not just that particular day or that particular treatment.
Wonderful. So again, just to reiterate, you're offering an unbiased approach to their disease. You give the patient their options and they ask you again, but what's my best option? So how do you answer that? And what makes prostate cancer unique in that you do offer the patient all these different options and really try to bring the patient in the decision-making process?
So, there are some patients that the decision is pretty much straightforward. A patient who may present with high-risk disease, or a patient who has low-risk disease, where we're really going to work hard to convince them to do active surveillance. And And so, our approach is going to be to try and convince them that, this might work. They may have other comorbidities, they may have other medical conditions that preclude one way or another of treating them. And so there is a subset of patients for whom, even without opinion, that we think one approach might be the best approach. And again, because we offer all the various ways of treating men with the experts to do so, it's comfortable to assign them as such. And then there's other patients who truly do have options in the context of they could have a seed implant, they could have a radical prostatectomy, they could have radiosurgery, and so then the discussion really comes down to what might be best for them. And so anytime we do any decision making is associated with risk versus benefit, and so it's important that there's an understanding of what the potential benefit is in terms of cure of the disease and eradication of the disease and the long-term outcomes associated with that, weighed against the risks. What are the side effects and the downside of those treatments? And that's where on the risk side, on the downside or the side effect side, you can start to peel the onion in terms of, what the patient's opinions are and what makes sense. Are they deadly afraid of surgery? Are they deadly afraid of radiation? The anecdotes of, my golf buddy had this or my other golf buddy had that, and, he did great and he didn't do well, and really start to peel back those types of discussions with the patients and the families to work with the decision process. But a lot of that is really on the risk side, because the benefits generally in terms of control of the disease is pretty much the same. And then it's trying to understand, I like to think of it as sort of the concept of least regret. Are you going to, if you have surgery and you fail, not that most men fail, are you going to regret that you chose surgery? If you do radiation and you fail, you're going to regret that you didn't have surgery. And so, when you start to have those types of conversations with the patients and their families, you can start to see, what might be, the best way for them.
Oftentimes many patients come in with fairly preconceived notions that surgery is the best way to cure my cancer, or radiation is the best way to cure my cancer. And I think, one of the first messages for most of these patients is to get across is that, listen, you have two excellent treatment options with excellent cancer control outcomes. So, once you kind of remove that barrier for patients to help them understand that whether they have surgery or whether they have radiation as their primary treatment, for most circumstances, the outcomes are relatively equivalent in terms of curing your prostate cancer. So then once you kind of move past that, then you can really start getting into some of their quality of life issues, some of their other notions and desires about how their treatment should go. And that's really where I think it's oftentimes easier then to whittle down to what is the right treatment for that particular patient. If a patient just asks, well, what's the best way to cure my cancer? Yes, oftentimes there's not a right answer because they're both outstanding treatments. But once you start moving past that question and saying, okay, well, which may be the best treatment for me based on my quality of life, based on my lifestyle, based on my risk tolerance, based on my family's opinion, and so forth, then my perception is that in most of those cases, you're able to really come down to a decision that's good for the patient. That you start peeling away those layers, as Dr. Potters mentioned, you get down to the core of what the patient is really looking for.
Thank you. You both clarified that very well. Can I ask you, how long have we been using this collaborative approach at North Shore-LIJ, and what have the patient perceptions been? How has it been received?
So we've been doing this clinic. Dr. Cavusi, who's the chairman of urology, and myself started this program about 4 years ago, and we've had some fits and starts, and now that we're all in the same facility together at the Center for Advanced Medicine and Late Success as the hub of the cancer program for the health system, we're starting to do this program, in more earnest and with other radiation oncologists and other urologists. It's really interesting to look back at the program and how the patients responded to it. Most of the patients are extremely positive of the time taken by the two physicians at the same setting to review this with them. And so patient experience and patient satisfaction is extremely high, with this program. What's interesting is of the patients that we saw or that we've seen, almost 40% of the patients are eligible for, and because of the consultation, will sign up for active surveillance. And the concept of active surveillance is that it means that disease has even a smaller C. It's like a sub C rather than even a small C, rather than a capital C. And it means that time is going to define for us whether or not that disease progresses. And our role as physicians is to then monitor the patients and to make sure to treat them if they need to be treated at an appropriate time course. But to get to a number where 40% of consults seen in this combined clinic accept active surveillance as an initial approach for managing their disease is huge, because around the country the number is about 15, maybe 18% of men will choose active surveillance. What that also does is it allows us to establish a long-lasting relationship with the patients. We get to know the patients, we get to know their spouses, we get to understand what makes them tick, and so that as we monitor those patients, if they were to evolve into needing treatment, the decision-making process is that much easier for them. And then for the other 60% of men that we've seen in the clinic who do require treatment or elect treatment, it's really been a sort of an even split in terms of 50-50 as to whether they have surgery, removal of the prostate, or they choose one of the radiation options. And so it's from my perspective, it's been a very rewarding, approach. And the patients, become ambassadors to us as their health givers, and also to the health system as a way of bringing them into this type of program.
Thank you.
I mean, ultimately, I was going to say, ultimately, most patients, if you ask them, prefer and like the idea that there is a team of experts that is looking at their particular case and, going about and trying to come up with the best decision rather than just one person.
Thank you. I want to jump in with some questions that we're getting live. So my first question is, when meeting a patient, do you ever disagree on what you think is the best approach for that patient? And then how do you decide how to proceed?
I would say it's not so much that we disagree, but we would agree that there are two great options for them.
And so then does the patient have to do the tiebreaker, or how does that work?
Ultimately, the patient is always the tiebreaker. The patient is the ultimate decision maker in terms of deciding which is the best approach. But, and we have this debate all the time in terms of, what is the pro and con of both, for surgical side, from a radiation side. But again, it goes back to, once you move beyond what's the best treatment for their particular cancer, then you start looking at, okay, well, what are the patient's desires? What are their quality of life issues that are going on, and how will each of our treatments potentially affect that? Most patients are able to make that kind of decision and come to some conclusion about what to do.
It's a little bit of a humbling experience to work as a physician with a colleague, making these presentations to the patients together, when in fact the option of radiation or surgery is truly a 50-50, roll of the dice option for the patients, and it really works to lower our guard, so to speak, on the presentation of our biases. Because, at the end of the day, we might walk out of the room and say, you sort of presented a little bit strong, or maybe enough. And,
too hard of a push.
and I sort of mean that sincerely. It is a little bit of a humbling way of dressing down our biases, in the presence of the patient, and I think that's huge. And as Dr. Vira was saying, ultimately it's the patient who has to make the decision, and it's no skin off my back if the patient is a good surgical candidate who likes surgery, because they've had the option, they've had the opportunity to hear from both of us, and they've made that decision.
So basically, you're checking your biases at the door, or at least you're trying to, right? So another patient asked, I have prostate cancer and I've only met with my radiation oncologist for treatment. Should I meet with a urologist?
I mean, the answer I think comes down to, again, it's about making sure that a patient is informed of all of the pros and cons and really gets an unbiased discussion. And no matter how much I might try to do that in a consultation with a patient that I'm seeing, by myself with prostate cancer, I begin my discussion with saying, listen, I'm a surgeon. There's some biases that I bring to the table. The fact that I like, that I do surgery. And at the end of the discussion, is that you really should see a radiation oncologist as well. So no matter how much I explain what radiation may be like, they're going to come with a different approach. So, I would argue that it's probably never a bad thing to get as much information as possible. Is it absolutely necessary? Maybe not for everybody, but I think in most cases it does make sense.
Yeah, I would say the short answer to that question is yes. You probably should see a surgeon and have a discussion about surgery. But as Dr. Vira said, you gotta tailor it. Usually the urologist is the one who sees the patients first, because they're the ones who are biopsying the patients and usually have an opportunity to present the results of the biopsy as a way of initiating discussion on treatment. So, but the short answer is yes, he should see one of the two.
So each consult
the radiation oncologist
to empower the patient so that they can make their best decision. Another patient just wrote, my doctor recommended active surveillance for my treatment, and I'm concerned about not being treated. Number one, should I get a second opinion? And number two, are there patients that you wouldn't offer active surveillance to?
So, I mean, this is a question that comes up all the time in terms of not every patient, even though their tumor or their characteristics of their cancer suggest that active surveillance would be the right approach, not every patient is geared for that. So if you see a patient and you ask them, when you leave my office, are you going to be worried? And is that going to affect your quality of life for the next 3 months until you see me again to check your PSA? That patient may not be the ideal candidate for active surveillance, because again, quality of life is an important aspect in terms of determining what approach is right. So if their quality of life is going to be detrimented by the fact that they are emotionally worried and that's going to affect their daily living, then active surveillance may not be the right approach for that patient. Anytime we're recommending active surveillance, sometimes the discussion is actually longer than when we are recommending treatment, because it's important to help the patient understand the strategy around active surveillance, helping them to understand that we're not saying, I'm just going to see you in 5 years and then we'll see what happens. The idea is to really actively monitor the tumor, look for any signs of growth, look for any signs that this may be more aggressive than what we initially had thought of, and then initiate treatment when necessary. So, should that patient see a second opinion? Well, if they're not comfortable with the plan for surveillance, then maybe the answer is yes. But it doesn't necessarily mean that active surveillance is wrong for the patient.
There's an old-fashioned term, and it's sometimes confused with the concept of active surveillance, and that's called watchful waiting. And so, a lot of men think of active surveillance as watchful waiting, and I think it's important that we define both those terms, because they're antithetical to each other. Watchful waiting is the idea of just sort of setting out to pasture a patient with a diagnosis and waiting for something to happen. Whereas active surveillance is a process of follow-up with either the urologist or the radiation oncologist at routine intervals to reassess the disease in such a way that you don't want it to progress or migrate or to change in a way that then requires treatment. And so my role or our role as a team is to not create any risk to the patient in terms of what their long-term outcome is, because any change by the fact that we have them on a set regimen is going to be addressed quickly and appropriately if the disease changes. And the data shows that at over a 5-year period, it's about a 50-50 mix. I mean, you could argue one way or the other, but about 50% of men on active surveillance might, and some data might suggest it's even closer to 60 or 65%, may require no treatment whatsoever over the course of 5 years. But that doesn't mean they aren't seeing us over those 5 years or being biopsied. And as Dr. Vira said, and what I tell the patients are that, they have a ripcord. They can pull the ripcord on active surveillance if the concept of living with the cancer is that disruptive in terms of their day-to-day and anxiety. But I can tell you that over the years, very few patients actually pull that ripcord. When the patients start to understand what the process is for active surveillance in terms of PSA being obtained, every several months, the use of MRI to evaluate the disease within the prostate, the rebiopsy aspect to confirm that nothing has happened. I can tell you that, very few men actually say, this isn't for me. They're okay with it. In fact, it sometimes goes strongly the other way, where, patient now gets rebiopsied and we sit down and say, okay, it's unfortunate, but, it's time to now think about treatment and let's talk about a decision. And they say, well, can I get another 3 months or can I get another 6 months? And sometimes you're pulling the patients back, from that aspect because they think that they're going to be okay long term. So, again, the answer to the patient is, his level of comfort with the physician, but the concept of active surveillance is something that's totally legitimate. And the fact that that's being recommended to them is likely a result of their physician having put some thought into the concept.
Well, thank you both so much. I think both of you were very concise and very informative, and I really appreciate you taking the time. We want to thank all the viewers and all the different questions that they submitted. If any of the viewers want to learn more about the collaborative approach to prostate cancer, they should visit NorthShore-LIJ.com, or they can actually call the North Shore-LIJ Cancer Institute at 855-858-8550. Thank you both so much. Have a great day.
Thank you.
Thank you.